Director of the FMER, and I'm very happy to welcome all of you to the first FMER Advanced Seminar of this year, 2022. So I will stop here. I will give the word to the two FMER affiliated students who will host this event. So Ad, Sima, the Zoom floor is yours.
Thank you, Dr. Rodriguez. Hi, everyone. My name is Sima Zahedi, and I'm a first-year master's student at the Department of Family Medicine. I'm working on resilience of primary healthcare providers regarding their mental health under supervision of Dr. Rodriguez.
Hi, everyone. My name is Ad Samman. I'm also a master's student in my first year at the Department of Family Medicine, Medical Education Concentration under the supervision of Dr. Char Rodriguez. I'm working on simulation for family medicine resident in the postgraduate training program regarding obstetric and gynecology services. McGill University is on a land that long served as a site of meeting and exchange among indigenous people, including Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse indigenous people whose presence mark the territory on which people on the world now gather.
We appreciate Dr. Hélène Givron for presenting today's webinar titled Learning Medicine, Learning Communication, an investigation of medical students' attitudes toward communication skills training. Dr. Hélène Givron currently supervises communication skills training at the University of Namur Faculty of Medicine and teaches a course in ethics and course in communication to nursing students in Belgium. She is leading studies on medical students' attitude towards communicative skills, their level of empathy and well-being. She is the co-leader for communication group of International Francophone Society of Medical Education, SIFEM. Before starting the webinar, I should recall that the presentation would be around 30 minutes, and then we have 25 minutes for discussion. We will record the seminar, so if you don't want to be in a recording, just make sure that your camera is off. And also, if you have any question, the questions can be posted on chat box, or you can just raise your hands. Thank you.
Thank you very much. I will share my screen. Okay. So hello, everyone. I would like to take this opportunity to thank Charo Rodriguez for allowing me to speak today, and also to thank Sima and Had for moderating this event. So to begin, I will briefly introduce the context in which our studies took place. I will then define the terms professional communication in healthcare and the terms attitudes towards communication skills learning. I'll then present the issues that we have identified both at local level, so in the curriculum offered by our Faculty of Medicine, but also at the more general level in the literature. I will then share our results and practical implication of our studies conducted in relation with this topic. And finally, I will conclude this presentation with a summary and followed by some perspectives. So this research took place in the context of my PhD thesis. I was hired in 2016 by the Department of Psychology at Faculty of Medicine in the University of Namur, so in Belgium. And I was hired to contribute to the development of communication skills over third-year medical students. So as a doctoral assistant, half of my part was dedicated to the implementation of this new learning device aimed at developing communication skills, and half of my time was dedicated to carrying out studies on this topic. And so the overall purpose of this research was to study the attitudes of medical students towards learning communication skills. So before presenting the content of our studies, it seems important to first look at what professional communication in healthcare is. In this research, we refer to the definition of Claude Richard and Marie-Thérèse Lucier from the University of Montréal, who defined professional communication in healthcare as both the master of a range of communicative behaviors, for example, encouraging an open posture, eye contact, a welcoming face, but also the ability to adapt these communication behaviors both to the patient and the care situation. Indeed, some patients are more in demand of information than others, and patients will not be involved in the same way in the decision-making process if they suffered of a chronic pathology of which they are an expert than if they arrived in an emergency room potentially unconscious. And this is why in the following presentation, I will use the term communication skills to emphasize that there is not one right way to communicate that will be applicable with all patients in all situations. The third part of this definition is also that communication skills will enable the healthcare professional to achieve both professional and relational goals. So numerous studies over the last few decades have shown that the benefits of a good communication between a healthcare professional and his patient. The benefits are, first, on the doctor's side, better satisfaction, less risk of burnout and complaints about medical errors. On the patient side, also better satisfaction, fewer complications and better health results. And on the society side, also shorter hospital stay and less referrals to other specialists. And the good news is that communication skills can be learned. Numerous studies have shown that it is possible to train both the communication skills of both medical students and practitioner, healthcare practitioner. So this is why in most of Anglo-Saxon countries, communication skills learning is an integral part of the medical curriculum. And you can see here the CanMEDS, which is the Canadian guide outlining the skills to be acquired to become a physician. And here, CanMEDS contains the communicator dimension, which is considered as essential as, along with others, to become a medical expert. Okay, so now the issues we have identified are the following. First, despite the cited benefits and evidence of that communication skills can be learned, until 2016, there was no course aimed at developing communication skills over medical students in our faculty at the University of Namur. It was the first problem. And secondly, the literature indicates that despite the implementation of communication skills training, a decline of communication skills and attitudes still occurs, and particularly here during the third year, as actually it's when practice starts. So therefore, based on these two observations, two goals emerged. The first one was to create a course aimed at developing communication skills of our third-year medical students. So concretely, all third-year medical students follow a mandatory course of 15 hours of medical psychology. And from 2016, 5 of these 15 hours were dedicated to learning communication skills. As I said, it has been proven that communication skill can be learned. And for this teaching to be effective, it must be theoretical and experiential teaching. So just like becoming a good surgeon, it's not possible, it's not enough to read a book on communication to become a good communicator. So according to Susan Kurtz, the next step, so after theory, is to observe role models practicing, then analyze what have been observed, then practice yourself, and then finally receive a debrief on what has been done. And so here is the structure of these 5 hours of classes dedicated to learning communication skills. So here, 2 hours of on professional communication skills, then 1 hour of observation and analysis of physician in real interactions with their patient, and then 2 hours here of simulation. So filmed role play followed by the viewing and debriefing of the video of the role play. And so the second goal, based on a review of the literature, a second objective for this research was to examine one of the causes of the non-transfer of learned communication skills to clinical practice, attitudes. So what do we mean by attitudes? Sometimes you hear people say, I like this physician because he has very gentle, a very warm attitude. This is the use of the term attitude in the behavioral meaning. In this research, the field of the literature in which we are situated in is socio-cognitive field, and therefore we will define attitudes as students' evaluation, so positive or negative evaluations of learning medical communication skills. And these attitudes are very important when looking at communication skills of our medical students, as they influence how to communicate, the communication skills training. So CST is communication skills training. I will use this later on. So how the CST will be received, the amount of time students will spend learning the skills, and how students will use them when dealing with real patients. And this is the most important, actually. And according to theory of plain behavior, attitude is an indirect predictor of the implementation of a behavior, as illustrated in this figure. Okay, now that the framework for this research have been established, we will move on to present our methodology and studies. So 5 studies took place within a quantitative sequential research design. And then the result obtained at the end of each study informs and contributed to the creation of the research question for the next study, and so on. In this presentation, I will focus on the last 3 studies of my PhD thesis that explore attitudes of medical students towards communication skills training. So, stage 3, the objective of the first study was to validate a questionnaire measuring attitudes of our students in a French version. And you can find this questionnaire translated and validated in the journal Pédagogie Médicale. So Rees, Short, and Davis have created the CSAS. You can see here, CSAS is Communication Skills Attitude Scale. This questionnaire contains 26 items scored on a Likert scale ranging from 1, totally disagree, to 5, totally agree. Half of the items assesses positive attitudes towards communication skills training, and half of the items assesses negative attitudes. An example of an item assesses positive attitudes is, for me, learning communication skill is essential to become a good physician. Now, an example of an item assesses negative attitudes. Here, it's for me, learning communication skill is essential for psychology students, but not for medical students. We already have so few class hours. They should be dedicated to biomedical courses. Okay. So, in addition to validating the questionnaire, we also collected socio-demographic data from our students and career preferences. As the literature often, the literature associates communication skill with so-called human-oriented specialties. For example, gynecology, general practice, and less so with so-called technology-oriented specialties, such as anesthesiology, radiology, and so on. And so we wanted to know to what extent do our students' attitudes differ according to socio-demographic variables and career interests. And the results are as follows. Three main results emerged from this data. The first one was that men showed significantly lower positive attitudes and higher negative attitudes towards communication skill training than women. This result is frequently found in the literature on attitude, but also on communication skills. Secondly, students interested in technology-oriented specialties, same patterns, showed lower positive attitudes and higher negative attitudes toward communication skills learning. And finally, students who wish to pursue a career exclusively in hospitals show lower positive attitudes. And these last two results are interesting, as literature often associates communication skills with physician practicing certain specialties. But here our results inform us that prior to practice, different attitudes already exist among students interested in different specialties and different work settings. So, okay, now the practical implication that we can draw from the studies are as follows. First, now we have a valid measurement tool in a French version to measure attitudes. Then, in order not to contribute to the belief that communication skills are more useful in certain specialties, in certain work contexts, it seems important to, in CST, to involve trainers from different gender, different specialties, work contexts, and so on. And also to construct clinical vignettes that for the role plays that take place in different clinical settings involving different specialties. Because if you look at the setup we had created, I saw a woman, a psychologist, was leading this communication course. And also about the vignettes, it was the seminar took place in a non-hospital setting and involved a general practitioner. So it would be very interesting to propose different setting. For example, a scenario that took place in the emergency room and that teach a future radiologist to maintain a good communication with his or her very anxious patient during an ultrasound, for example. So now, stage 4. Stage 4 of our research design allowed us to explore the role of emotional competencies in predicting medical students' attitudes towards communication skills training. So why emotional competencies? Previous studies have identified particularly high levels of stress, anxiety, and even depression expressed by medical students. And it's easy to imagine that if you are overwhelmed yourself, you're less likely to invest in communication skills training. Conversely, emotional skills prevent the risk of burnout and the decline of empathy that occurs as medical studies progress. Thus, in the questionnaire preceding the first course of communication skills, we collected a measure of emotional skill, depression, and anxiety in our medical students. And in another collection carried out each year among the students, before the first internship, we took measure on about empathy and burnout. And the results are as follows. So gender and emotional skills are significant predictors of students' attitudes. More precisely about the emotional skills is the intrapersonal emotional skills, utilization of one's emotion that participate in predicting positive attitudes. And in concrete terms, it's the it's perceiving one's emotion as useful, informal, informing you of potential change that could be made in one's life. And so conversely here, the higher this competence is, the less likely students are to present negative attitudes. And the interpersonal skills, emotional skill, listening of others' emotions, is also involved indirectly in predictive negative attitudes towards communication skills. Okay, so this is for the emotional skills, and now about burnout and empathy here. So high score in empathy and low score in burnout explain 31% of the variance in positive attitude. More precisely is the subskill perspective taking. So this is the ability to take the other's point of view when having a discussion or and so on. And empathic concern is the tendency to care about others, and fantasy is the ability to imagine, for example, how the main character of a novel feels. So all of this will predict higher scores on positive attitudes here. Okay, and now about burnout. Burnout is assessed by 3 subskills. The first one is cynicism, so seeing others as number. The second one is emotional exhaustion. And the third one is academic accomplishment. So it's feeling accomplished in one's studies. Since this is a questionnaire that measuring burnout in the student context. Okay, so the more accomplished the students feel in his or her studies, the less negative attitude the student will have. And about cynicism, the higher a student score on the cynicism subscale of the burnout questionnaire is, the more negative attitude, the more negative attitudes the students will have. So now, the practical implication. So this study invites us to consider that when looking at students' attitudes towards CST, we also need to consider their emotional skills and their well-being. And based on this result, we advocated for and obtained 10 hours dedicated to the development of the well-being of our medical students. And this course has taken place for the first time this year. And we are currently analyzing the results of this, so the impact of this 10 hours lessons on the well-being of our students. So their levels of empathy, the levels of depression, anxiety, stress. This is very exciting. And now the fifth and final study examined the attitudes of students longitudinally. You can, details of these results can be found in the publication in the review Patient Education and Counseling, as well as for for study 4. So, as shown at the beginning of this presentation, despite the implementation of communication skill training, a decline in communication skills and attitudes occurs, and specifically here in the 3rd year. And this is precisely the year in which our students find themselves. And when we look at the literature, we learn that the 3rd year is when CST and practice start. So briefly about practice, when supervision by a physician that are not always exemplary role models for communication, maybe a part of this explanation, but more precisely about the CST. In focus group, Belgium researchers, and more precisely Catherine Bombeke, identified that students reported having developed negative attitudes toward communication skills training, following particularly negative feedback from simulation trainers. So it seems that this negative feedback would lead them to re-evaluate this course more negatively. And based on this observation, it became necessary to, well, it became essential to verify that our CST was not deteriorating the attitudes of our students. And so, as you can see here, we measured our students' attitude at 4 measurement types. We measure our students' attitude before the CST, so it was in September 2018. Then after the CST in December 2018, and then all of these students participate in their first mandatory internship. It's a 3 weeks observational internship in general practice, and therefore we measured the attitudes both before and after this traineeship. And a total of 105 students answered the questionnaire at the 4 measurement types. So here are the results. First, here, so in the graph, after our 5 hours CST, the negative attitudes of our medical students significantly decreased, and their positive attitudes significantly increased. So this was the good news. But 6 months after the CST, so 6 months without CST, you can see here that the negative attitudes of our students already increased and significantly increased. After a traineeship of 3 weeks in general practice, so here, no significant change in attitudes have been observed. Also, in addition to the CSASF, so questionnaire measuring attitude in the French version, our questionnaire contained also open question asking students, did the 5 hours of the CST change your attitudes, positive or negative evaluations of learning medical communication skills? Please briefly explain. This in order to gain insight into what may have contributed to the change in attitudes over time. And so thematic content analysis confirmed the results of the quantitative results. Indeed, none of the students reported a deterioration of their attitudes. And when explaining why, what they thought contributed to their increased positive attitudes, they highlighted three points. So the first one, theory. The first commonly held negative attitude is that communication skills cannot be learned. It's innate. One's born good communicator or not. And when students learn models and theories on professional communication in healthcare, they suddenly realize that, okay, communication skill can and probably must be learned. The second is the practice. A second commonly held negative attitude is that communication is learned by doing. And when students are in role play, they realize that, okay, communication skill training put themselves in practice. So maybe it's possible to learn communication skill in the context of communication skill training also. And then finally, a third widespread negative attitude is that communication is easy. But when students are in role-play and simulation, they often realize that this is much more complicated than what they thought. And so after the role-play, students often have a better understanding of the value of the CST in their curriculum. So this fifth study concluded the importance of teaching communication skills longitudinally. Indeed, after 6 months without CST, the negative attitudes of our medical students are already increasing. Also, beyond the importance of practice for development of communication skills, our thematic content analysis showed that practice was also very important for fostering positive attitudes towards communication skill training, confirming that communication can be learned through practice via simulation and by raising awareness of the medical students, the complexity of the physician-patient communication. So practice is important, but furthermore, theory is also essential as it informs medical students that of the scientific approach to this professional skill that should not be reduced to an innate skill. So at the practical level, this result showing no deleterious effect of our CST on attitudes of our medical students allowed us to maintain the CST and even advocated for and received more hours. So more precisely, we received 10 hours exclusively dedicated to CST. So there are still 15 hours of medical psychology plus 10 hours of CST in the curriculum offered to third-year medical students. And in addition, to help students link communication skill to other clinical skills, another interdisciplinary project with the semiology course was created. So finally, this inductive sequential approach allowed for the construction and the testing of a model. This is to provide a framework for studying attitudes in the future. And as you can see here, 15% of the variance in negative attitude is accounted for by gender and interpersonal emotional skills. And 16% of the variance in positive attitudes is accounted for by gender and desired specialties. Now, the various practical contribution enabled by the studies are summarized here. So first, as already explained, it is necessary for CST to include both theory and practice to foster positive attitudes toward communication skills. Then it's important to involve trainers from different specialties and practice settings, and also creating clinical scenario that place students in a variety of contexts and also involve different specialties. This is to ensure that they understand that communication skills are essential for all healthcare providers, regardless of the care setting, care situation. Since attitudes are related to students' levels of burnout, students' level of empathy, we must look at their well-being also, and not just be focused at the communication skills, Okay, so CST should be longitudinal indeed. We already have seen a significant increase of negative attitude after only 6 months without CST. Another point, the current pandemic context brings new communication challenges. And during the first lockdown, we adapted slightly the content of our CST to the situation. For example, by addressing the particularities of teleconsultation. And actually after that, the students reported that it helped them realize how communication skills are useful for the future profession. So insist on the useful character of learning CST. It's also very important. And finally, based on our positive results, as already mentioned, we have 10 hours of CST, and this year, 2022, we'll have 20 hours of CST. And also all second-year medical students now have 10 hours of courses aimed at the development of their well-being. So the research perspectives are as follows. We have collected data only on students from our university. So now it would be interesting to see if these results are generalized to a more larger population. Then, according to theories of applied behavior, students' attitude predicts the transfer of learning to practice. But the students we studied were in their preclinical years. So it would be interesting now to follow them to observe this potential link between their attitude and the transfer of their learning into practice. And also to observe the links between attitude and their actual behavior in practice. Finally, our thematic content analysis offers some suggestion, but it will be very interesting to further investigate the processes underlying positive and negative attitudes of our medical students. So thank you very much for listening. I think there is no time for questions, so I will stop my share screen. Thank you. Yep. Yes. And yes.
Thank you so much, Dr. Ellen, for this interesting presentation. I can see that many people raise their hand. They want to ask some questions. So I will start with Dr. Pluy, then Izzy, you can, then Dr. Tiber, you can go after.
Sorry, I uploaded, but I can ask a question. Congratulations. Merci, Hélène.
Thank you very much.
However, so I have the opportunity, so maybe it's a comment rather than a question, but regarding the perspectives, I guess the organization, if we look after the training, but if we look at the residency and practice in a longitudinal manner, as you suggest, which I think is a fantastic idea, then I guess the organizational culture in the clinical setting will be, looking at that organizational culture will be essential, as it won't be just only a matter of attitude and behavior, but more like how the clinical setting environment actually allows these, the new trainees and the residents and the new physicians to continue to work to at least stabilize their communication skills, right? What do you think?
Well, as I said, our students were in preclinical years, so I have no measurement of about that. But I think that the organizational culture will probably influence the attitudes of the students, because if there is no possibility to train their communication skills, it probably implicitly suggests that communication skills are not that important for the profession. That's a comment back in the, yeah.
Dr. Tiber, you have a question?
I didn't want to cut the line. I think Izzy was first, but I can go first. Doesn't matter. Yeah, thank you for this very stimulating presentation. And it's, first of all, it's great to see what a nice research environment students or academic units are, you know, because you have a cohort, you can do several projects that align with each other. I think we should take more advantage of that. So my background is biostatistics, and especially causal inference. I'm very into methods, and my question, and you may not have an answer, but I think it should be a discussion point in general. So your research findings found that gender, for instance, is an important predictor for, you know, emotional competencies and for communication, and also emotional skills. Now, my question from a causal point of view is, what do we do with this information? What do we do when we learn in a study gender matters? Because ideally, we look at factors we can intervene on, right? We look at, let's say, baseline education, baseline training. If we see the baseline that's a predictor for something in the future, we want to raise that baseline level. Now, we cannot really act on gender. We cannot say, now all you take on a different gender. And I'm not sure about emotional skills, are those hard skills, are those soft skills? So my question to you would be, in your practical recommendations, how to move forward, how would you take that into your recommendation, what to do? Like, I mean, that's really my curiosity.
I'll say maybe involve trainer from different genders, because it implicitly vehicle also that maybe communication skills is associated with women, or for example, I as a woman was carrying out this course, and maybe implicitly that confirmed this belief. It's maybe about the trainers that we can have a power of action, but otherwise, yeah, it's limited, of course.
Yeah. And my comment would be on that, and I think sometimes we may have to even go a step further in the analysis and look in what are other factors mediated through gender, like where gender is affecting something that can be intervened on, you know, certain lifestyles, certain educational choices, sociocultural choices, and also the role of gender as a fact modifier can be interesting, because then you have another variable you may be able to act on. So it makes it more explicit, I think, in terms of recommendation. But I would agree, like starting with representation, or a good representation of different genders in that case, it's a step forward.
But there are good suggestion, more statistical suggestion. Yeah, it's interesting. I will read them.
No worries. Thanks a lot.
Thank you.
Thank you, Dr. Ellen, for answering the question. Now, Izzy, you can ask your question, and then Dr. Marindo.
Okay, hi, Helen. Thank you so much for the great presentation. It was really, really interesting. Since you increased the hours of this CST training, I'm wondering if there's a specific reason you doubled the hours. I'm sure you do have a specific reason. I'm just wondering.
Well, we've asked for more hours, not especially double it, but we received 10 hours. But our idea is to use these 10 hours to train students to interprofessional communication this time. So 10 hours about communication, physician-patient communication, and 10 hours about interprofessional communication. So the idea is to putting them in simulation with nursing students to train them to interprofessional communication. So this is the project, and I hope it will be possible.
I hope so too. Thank you.
Thank you.
Dr. Marindo, you can ask your question now.
Hi, thank you. I want to thank you first for the very interesting presentation. I have to say, I'm a clinician in the Department of Family Medicine, and I'm also the chair of the department. I was shocked that you mentioned that there had been no communication skills training at McGill University prior to 2016. And I don't know how long it's been going on in all Canadian universities, but I started my training in 1991, and we had communication skills training in our first year for 1 hour per week or 2 hours per week. Anyway, it was significant. So when the previous questioner asked about why you doubled the hours, I'm like, okay, I think 20 hours in all of medical school is still a fairly small amount. It's been shown over and over that there's improved patient and provider satisfaction with better communication, that there are fewer medical legal problems, that there are probably better outcomes. And in fact, I think maybe the discourse and the challenges in some of our medical education programs in family medicine at McGill is that sometimes people feel we've gone too far. We spend too much time on communication skills, and residents and students aren't learning enough about the hard stuff. That being said, I thought your research was very interesting, and I certainly, all of your findings resonated with me, but at the same time, I guess the comment that I sort of have as a medical educator is, I don't really care if the medical students like it or don't like it, they have to do it because that's what they have to learn. So I guess I just wanted to bring that point up and see if there was any sense from your experience, if there is a little bit more push or agreement that the communication skills training should be increased even further.
Well, first of all, the situation is very different in your country than in ours. But about this point, I think that I will refer to the theory of planned behavior that show that this is important to be interested in this, to get involved, and to pursue the learning of communication skills. And the idea is very it's maybe because I am in contact with students in their preclinical years, and then no more, but I was very afraid of giving them 10 hours and then that nothing happens after. And so the idea was to I don't know in English, but give them the love of communication, or the interest to hoping that therefore, later on, they will pursue this learning and practicing later. Sorry, it's hard for me to improvise in English, but I hope you understand my point of view.
Yes. No, thank you. That's a very, very interesting. And I guess I didn't mean to imply that I don't think it's important for medical students to be interested in communication skills. I think obviously they're going to learn much better if we can demonstrate to them the importance of it so that they are interested. So yes, absolutely. I think it's very important that they be interested and engaged.
Maybe another perspective is to make them realize the importance with the more scientific approach. I think that works too, because they are interested in scientific evidence. So it's another way to act, I'm sure.
So thank you all. By the end, we thank you all for being in this seminar. The next seminar also offered by research program on March 18th, also at the same time, 12:30, offered by Dr. Nell Anderson with the title of Safe Birth in Cultural Safety, Global Experience Can Build Local Solution in Quebec Family Medicine. You can find the registration link and information for both seminars in the chat now. Thank you.
Thank you for having me today.
I would like if you let me finish a little bit, wrap up the seminar. I wanted to congratulate you and for your generosity for accepting this invitation. But also I would like, and for the students that are participating, attending this seminar, the coherence of your thesis and the way that you have presented your work, the link between the research questions, the methodology that you adopted, the way that you have presented not only the results, but the implications for both theory and practice. I think your pedagogical approach has been fantastic for all of us, but in particular for the students that they are going through the process that you went for your thesis. So once again, thank you so much for everything. Okay, and also remind to everybody, we had the FMER organized another seminar. It was scheduled this year. It was scheduled on March 25th, but we have decided to postpone it probably at the end of April. So I will keep you posted about all that. Okay. Thank you. And thank you also to Sima and Ad for hosting the seminar.
Yeah, thank you very much.
Thank you. Thank you all for the attendance. Bye.
Thank you.